So welcome. I'm William McKenna, and this session is on inherited cardiomyopathies in athletes. And note the title, A Ticking Time Bomb. That's an intriguing title. I wasn't quite sure what the organizers had in mind, but I started by going to Google. And there's a definition for us, a developing and problematic situation, which will eventually become dangerous if not addressed. And you could look at that and say, well, this is a patient with hypertrophic cardiomyopathy or arrhythmogenic cardiomyopathy. And as an athlete, there's a risk. I think I'm not going to focus on that because there's an extensive literature. We know how to diagnose these conditions and by and large have guidelines to manage them. What I'm going to be looking at and trying is what we don't recognize. And we know we are not perfect in this regard. There continue to be problems with athletes, and we probably stop athletes from participating inappropriately sometimes, and we certainly miss athletes who are at risk. So I'm going to be trying to get onto that frontier of the athlete that we have missed or misdiagnosed. These are the goals, and the first one would be to look at our understanding of the epidemiology of hypertrophic and dilated and arrhythmogenic cardiomyopathy. So, if what our perceptions are correct, then that's reassuring. But if our perceptions are wrong, and there's a significant proportion of individuals who fulfill diagnostic criteria that we're missing, then that will represent a problem to us. And maybe we're just looking at the tip of the iceberg. The second, and something that is increasingly apparent, is that most inherited disease, cardiac and otherwise, has incomplete and age-related disease expression. And this is the case for each of the cardiomyopathies. It differs, and it differs in relation to the different genes, but to what extent is this an issue in the diagnosis of the condition in athletes? And the second thing, does it matter? So if someone has a HOCM gene and normal echo with an abnormal electrocardiogram, is he at risk? And again, so we need to look at the risk of arrhythmia and sudden death in those who do not fulfill conventional diagnostic criteria. In other words, those who have either incomplete or age-related expression. And the final goal is actually to try and define it as best we can, the high-risk clinical situations where that ticking time bomb is most likely to go off. This is a classification, the European Society classification, which we're all familiar with. And it starts with actually the phenotypes of hypertrophic, dilated, arrhythmogenic, and restrictive cardiomyopathy. And we do our best to look at the family background, which is a key component where we can improve. And then if we're fortunate and have access and are fortunate to be able to identify the genetic basis, that's the sort of the full pathway. In this talk, I'm going to focus on the two conditions which are of greatest risk in terms of the ticking time bomb. That's hypertrophic and arrhythmogenic cardiomyopathy. With restrictive cardiomyopathy, first of all, the athlete it's rare to have an athlete who has severe restriction, and the restriction usually results in atrial enlargement, atrial fibrillation, embolic risk, and heart failure complications. So that's not what we're talking about. I'm also going to talk about dilated cardiomyopathy, not dilated cardiomyopathy with heart failure leading to advanced heart failure and LVAD, ECMO, transplant. No, it's the overlap between DCM and ACM, and a significant proportion of ACM patients get labeled as DCM because they've got an underlying structural or functional abnormality. So we'll go into that in some detail. So this is an easy one. This is not subtle. If you're screening athletes for one of the football team clubs, and this appears, full well, and the psychiatrist would make the diagnosis, these T-wave inversion, 1 AVL and V4 to V6, and there's a 3+ centimeter asymmetric septal hypertrophy with features of obstruction. This is not the ticking time bomb. We know how to diagnose and manage this. Now that this individual should obviously not be participating, but the management of this we do understand. Similarly, if we look at ARVC, which is the other condition where there's the greatest risk of a potentially lethal event, here we have clear criteria that have been refined recently, but go back to the mid-90s with the ECG changes, typical changes, T wave inversion leads one to AVL with delayed upstroke of the S wave. We also with epsilon waves and presenting with left bundle branch block ventricular tachycardia. And we know the imaging abnormalities on echo and more recently and better shown on cardiac magnetic resonance with late gadolinium enhancement. You see on the right-hand side of this, the histological correlate of what we see with CMR, where you see the fatty replacement coming in from the epicardium, invaginating into the myocardium with fatty and fibrous tissue replacement of dead and dying myocytes with a relative sparing of the subendocardial layer. And again, this is a disease we understand, we recognize, and by and large can treat. And we have guidelines which by and large are applicable and can be and work. These conditions all have a genetic basis, and the genetic basis will the variant involved, pathological variant, will differ in terms of expression and risk for for all three cardiomyopathies. So HCM is by and large a disease of the sarcomere, DCM of the myocyte cytoskeleton, and that's heart failure related DCM. And the arrhythmogenic cardiomyopathy is more diffuse. We're most familiar with the desmosomal variants, which cause ARVC, and the nuclear envelope, particularly lamin, which causes multiple phenotypes, and then more recently ion channel causing as well an arrhythmogenic cardiomyopathy. And there's many other genes which we'll come back to, but these are genetically different conditions. So at the outset, we're looking at prevalence. And if you open any textbook or review, it'll say something along the lines that hypertrophic is 1 in 500 and DCM 1 in 250 of the population. And these are mainly from screening studies in athletes, in military recruits, and in healthy young people trying to get a sense of cardiovascular risk, mainly American studies. And Barry Marin has been a champion, particularly of the hypertrophic ones in this regard. So does this current epidemiology, is that an underestimate or accurate estimate of disease in these three conditions? We're not obviously stopping, given the structure here of no audience, at live audience, but these questions will be brought up again at the end. But you should be looking and thinking, well, is the hypertrophic accurate? Is the DCM accurate? And for ACM, the estimate would be roughly 1 in 2,000, but the data is less accurate, less well established there. So these are questions you should be thinking about and have some sort of an opinion formed now. And then as we go on, that opinion may or may not change. So with hypertrophic cardiomyopathy, the data is largely from 1987 for the next roughly 15 years. And there are 9 studies. Again, Dr. Marin has been involved in many of these and the best ones. And this comes up with a prevalence of 0.16 to 0.23, which is roughly 1 in 500. When you drill down into these studies, one of the obvious things in 7 of the 8 is that hypertensive patients who had left ventricular hypertrophy of equal to or more than 15 millimeters were excluded. So that's the definition of hypertrophic cardiomyopathy, unexplained hypertrophy. But it was assumed that 2 conditions could not coexist, which we know that's not correct. Hypertrophic is roughly 1 in 500 and hypertension is common. So you're going to have people with both diseases. And if you correct, the prevalence comes up to 1 in 345 rather than 1 in 500. But ballpark, overall, the data from the Cardia study and others is roughly correct, 1 in 500, and maybe a little bit more. If you look in more detail, the early textbooks, Brownwald, Goodwin, they wrote hypertrophic cardiomyopathy is a disease of young males and older females. And we know that these are inherited conditions and that the genetics should be roughly, if you have enough people, it should be 50% male and 50% female. But the expression and the studies that have been largely performed in young males rather than females, I think accounts for part of that. The other is that the age range, that as you get in the older age groups, the prevalence is higher. And again, that's a function probably of age-related expression. The other feature that's striking in the data largely from the United States, is that it's higher prevalence in blacks than whites, which is not well explained. It may be the coexistent hypertension, but even in young blacks relative to young whites, it's still a higher proportion in blacks. So that's unexplained. If we look at dilated cardiomyopathy, here we have a very interesting dilemma. So to do a population study, do a proper epidemiological study, you should define your population. And probably one of the few very, very correctly performed was done by Mary Codd in working with Mayo Clinic people in Olmsted County in 1989 and published in 89. And they came up with a prevalence of DCM of 1 in 2,700. But what they did is they went in Olmsted County and they had access to all the medical records and the echo reports. And this is where they found a prevalence. From that data, they came up with this prevalence. Clearly in that time, first of all, M-mode echo was not that, the indications was not that extensively utilized, and the awareness of the cardiomyopathies of dilated cardiomyopathy also was much less. So this turns out to be, as we know, a gross underestimate of the prevalence, but it's useful because that study was performed in a rigorous fashion with a well-defined denominator in terms of the population. And in that same study, they found that hypertrophic was 1 in 5,000. Well, we know with pretty robust data that hypertrophic is somewhere around 1 in 500. So by extrapolation, DCM should be somewhere around 1 in 250, not 2,700. How is there data to support this? There's several, and I'm just showing 3 of the 3 bullet points. And I go back to a Mayo Clinic performed study in Olmsted County in upstate Minnesota. We're just taking asymptomatic left ventricular dysfunction based on echo, less than 50% EF, 6% of the population, and less than 40% EF, 2%. So these are very big numbers with asymptomatic unexplained left ventricular dysfunction. A second is if you look at the US transplant registry. And in 2015, there had been in that registry 16,091 patients transplanted with dilated cardiomyopathy, of whom 492 or 3% had familial disease. So you fill in a questionnaire, that's what gets logged on. And that's a very, very small proportion. That, the proportion of DCMs that are familial is usually somewhere between 30 and 50%, not 3%. A single center, Dan Jacoby at Yale, initiated a study from their transplant population, which is published in the reference there, Journal of Heart Lung Transplant. And they sent out a questionnaire and a telephone interview, and they had 26% had evidence of familial disease. And we know that if you then go ahead and do ECG echo on relatives, you get up around 50% in terms of familial disease. And then the next bullet point is, even when you know there's DCM and there's a proband, even within the families, there's still a significant proportion of people who do not get screened and do not get accounted for. And in this particular study from our group by Niall Mahan in the Annals of Internal Medicine, 51 of 767 asymptomatic relatives fulfilled diagnostic criteria within 5 years. So the conclusion is that a significant proportion of DCM actually goes unrecognized. And here, the point I want to make here, this is the data. So there's 186 probands and there's 767 asymptomatic relatives. And if you look, the left ventricular enlargement and depressed fractional shortening, significant numbers of patients, and those patients over a relatively short follow-up, and they're relatively young. So the follow-up's about 5 years, and I don't recall the age, but it's probably in the 30s. 16 of these people go on to develop disease over 5 years, which is together with the 35 who were found immediately to have both depressed fractional shortening and left ventricular enlargement comes to 7% in 5 years. So we know we're missing a lot of DCM, both for incomplete expression, but also not bothering to make the diagnosis in often people who are asymptomatic. Why do I go on about dilated cardiomyopathy when there's no, the ticking time bomb is more the development of heart failure, not sudden death? Well, because if you look at DCM, the definition is unexplained dilatation and impaired contractile performance. And clinical presentation is usually symptoms of exercise limitation, fatigue. If you look at the definition of arrhythmogenic cardiomyopathy, it's presentation with an arrhythmia, but you need to have a cardiomyopathy. And what happens in a significant proportion is the diagnosis is made in some of DCM is made even when the presentation was an arrhythmic syncopal episode or VT or frequent ectopy on a Holter. And the treatment is then initiated as if this is a heart failure patient with beta blockers, ACE inhibitors without risk stratification in relation to arrhythmia, an arrhythmia, conduction disease, VT, VF, sudden death. And when you look at, certainly when we look at pedigrees of families with DCM, this is not an uncommon occurrence. So the key is actually making the distinction between these two conditions, and a key element of that is the family history and pedigree. Because when you find that someone has died suddenly walking to work, that is very unlikely to be DCM caused by cytoskeletal disease genes, where the major outcome is related to heart failure. It's much more likely to be one of the arrhythmogenic cardiomyopathy genes. This is the these are the genes, some of the genes that cause arrhythmogenic cardiomyopathy, and that looks like a fairly intimidating and incomprehensible list. For instance, what is CTMNNA3, etc. In actual fact, I think we do know a fair amount about some of these conditions. So on the far left is plakophilin, desmogliin, desmocolin, desmoplakin, and plakoglobin. And these obviously are the disease genes that cause ARVC. We know a fair amount about LMNA, lamin. We know a fair amount about RBM20 and about phospholamban in Holland. I've put into red those conditions which actually present with, quite commonly present with an arrhythmogenic DCM, or what should be labeled as an arrhythmogenic cardiomyopathy. But the literature on desmoplakin, and the literature on lamin, and the literature on FLNC and RBM20 and phospholamban in particular often is in the DCM, and these patients often get managed as if they were typical heart failure patients. So it's quite important, this distinction. Is this an arrhythmogenic cardiomyopathy, or is this a dilated cardiomyopathy? Because the ticking time bomb here is sudden death. The ticking time bomb in dilated cardiomyopathy is the gradual decrease in left ventricular function and the development of heart failure. But that is a much more manageable scenario with a different management strategy and a different approach in terms of the athlete. Interestingly, for most of these genes, if you look at the allele frequency of the variants in the population, they're much higher than you would expect from the prevalence of these diseases in the society. So this suggestion is consistent with low penetrance and, again, incomplete disease expression. So, question in relation to what we've been looking at here. First, I guess, do most individuals with HOCM, DCM, or ACM have a variant that with a disease-causing variant have incomplete or age-related expression and go unrecognized or undiagnosed? And in hypertrophic cardiomyopathy, is that a yes or a no? In DCM, yes or no? In ACM, and again, we'll come back to that at the end. But you should have your own opinion at this stage. The next question is, so what? If there is incomplete expression, is there a significant risk of ventricular arrhythmia and sudden death? And again, having your own opinion going forward for hypertrophic dilated, and arrhythmogenic cardiomyopathy. And again, this will come back up in the moderated session at the very end. When the first genes were identified, so the first gene for heart disease was found in a large French-Canadian family with a myosin heavy chain mutation in from changing arginine 403 to glutamine. And in the first 53 patients with this mutation, so the 53 gene positive, all of them had an abnormal ECG and an abnormal echo. So nobody was incomplete penetrance, no incomplete expression. And this was by roughly middle adolescence. So this was complete expression. And that, at a naive stage of our understanding of genetic disease, this was what we thought happened. And it didn't take very long before we realized that in actual fact, that's the rarity. Most families have incomplete. So most gene pathologic variants are associated with incomplete and age-related penetrance, not with fully penetrant disease. So I've lumped together two papers here, heavily engaged from the National Institute of Health in the States. These two mutations in myosin heavy chain both present the feature of a normal echo with an abnormal ECG. So if you go to the right-hand column, say we start with 65 patients with this mutation, or one of these two mutations, and 27 of them have a normal echo, and of those 20 have an abnormal ECG. So here we have abnormal ECG, normal in imaging. And the question is, so what? So are these people nonetheless at risk? Well, with myosin, with the exception of one paper published from Holland, actually, in Heart Rhythm by Arthur Wilde's group, where there's a young lady with normal ECG and echo who dies suddenly with a myosin mutation. That's the one exception, but I think it's safe to say you do not die suddenly with a myosin mutation with a normal echo and normal imaging. Is that true of troponin I disease causing hypertrophic cardiomyopathy? This is the experience from our own clinic. This was published by Jens Mogensen in 2004. 96 individuals carrying a pathogenic variant in troponin I, and you'll see that 58 of them had a normal echo, and of those, 49 had a normal ECG. So most patients carrying this variant were normal clinically. And you'd say, well, mild disease, why are you calling this hypertrophic cardiomyopathy? Because in those families, you had extremely variable disease expression. And so you could have a grandmother who had mild 1.2 centimeter thickening with a maybe calcified mitral valve, whose daughter has T-wave inversion 1 AVL and a normal echo, and the grandson has 3 centimeter concentric hypertrophy, aged 15 and needs a transplant. Within the families, tremendous variation in disease expression, indicating either environmentally or modifier genes. But again, you did not die suddenly with a normal echo. And again, that very consistent through those families. Here is the exception, and this is on the right-hand side is histological features from a young lady whose detail I'll show you in a minute, who has extensive myocyte disarray. You see this is a myofibrillar stain. So the red, you can see the myofibrils, and there's complete disorganization, and it's surrounding areas of increased loose connective tissue, which is the white or sort of light blue that you see. On the left is a normal myofibrillar stain, which is, if you think about it, it's necessary for normal electrical transmission cell to cell. On the right is if you were designing an unstable electrical circuit for macro reentrant arrhythmia, that would be it. This is the pedigree. So the 21-year-old girl on the lower left, that was her slide. 40% of right and left ventricle showed that disarray. In the family, all 4 individuals who are deceased died suddenly as their initial presentation. So they had not had syncopal episodes, they had no cardiac symptoms, and the hearts were sent to Michael Davis, who was a particularly renowned cardiac pathologist in this era. This is about 30 years ago. And he noted that, and in the autopsy report, and this is published in the British Heart and Heart or British Heart Journal. He noted that these individuals had normal heart weight, normal wall thickness, presumably would not have fulfilled imaging criteria for hypertrophic cardiomyopathy, but they all had extensive disarray in the histological diagnostic feature. And he wrote in the report, until we know, is this hypertrophic cardiomyopathy without hypertrophy? And until we identify a disease-causing gene, we will not know. Ultimately, we found a mutation in troponin T in this family. None of these individuals who died had been seen prior to death, but the 23-year-old on the left-hand slide was evaluated and has been, she's now in her 40s. This is her ECG, and she was completely asymptomatic then and now. So clearly abnormal T-wave inversion, 1 AVL and V4 to V6, but definitely abnormal. And here's her echo. This is a more recent echo, but at the time she was in the M-mode era, she was completely normal. Her wall thickness is about 8 millimeters. Interestingly, if you look on the lower right, the more distal short axis view, she's probably about 10, 11 millimeters, which relatively you should be thinner as you go down the ventricle from base to apex. That probably or may account for the electrocardiographic changes. But here's a lady with either very mild or no LV thickening. So incomplete penetrance. Whoops, sorry. So here we look at data in a larger cohort. So this is published, the lower right, it's Hugh Watkins looking at our troponin T families. And if you just focus on the maximal left ventricular wall thickness, you'll see that the average in these families, 13, 15, 17, 17 and a half, 19, 17, 16 millimeters. That's much thinner than if you look in the upper slide, which is a summary of this, the myosin mutations, where on the right-hand slide, the people with the myosin mutation, the average wall thickness was 22 millimeters. And then if you look back down again on the troponin Ts, the number of disease-related sudden deaths, and it's 4, 11, 14, 9, 1. So significant number of sudden deaths. And the first family, the intron 15 G to A splice site mutation on the right-hand side of the slide, that family, those individuals who died suddenly 8 of them were under the age of 30. So this is young people dying suddenly with, now most of them were not seen characterized prior to death, so we don't really know ECG and echo, but it's no question you can die suddenly with very unexciting and not fulfilling unexciting features and not fulfilling diagnostic criteria with troponin T, which is in contrast to the other genes that cause hypertrophic cardiomyopathy. So is there a major risk of sudden death with normal or non-diagnostic echo in association with disease-causing mutation? Again, we'll come back to this, but with myosin heavy chain, troponin I and troponin T, there are differences, and there are important differences. And one of the rationale for why gene testing is actually has clinical utility. What about ARVC? So when we see ARVC, we usually are thinking and recognizing the overt phase. And we know that sudden death is a risk. We have diagnostic criteria. By the time that this occurred, the overt phase, we usually have structural abnormalities, which allow you to pick up features on either echo or MRI. The problem is not the overt phase. The problem and the ticking time bomb is actually the concealed phase. And here we know sudden death can occur, and yet the clinical features, presenting features, may be fairly modest. And if we look, this is our experience of the first 100 families with ARVC, and roughly 49 of them, roughly half, the proband had presented with sudden cardiac death at the ages shown. And you can die suddenly from ARVC at any age, but clearly we're not picking up disease when you see this number of sudden deaths and the way that these families are presenting. The sudden death is the initiating event that allows diagnosis. So it's not that shouldn't be the case. We should be finding disease. We need to find ways of finding disease before the sudden death occurs in someone. This is a broader cohort from the Inherited Cardiovascular Disease Clinic. And this was presenting with unexpected sudden death and post-mortem diagnosis of ARVC or the finding of ARVC in a family member during the screening. So 74 deceased individuals, and the standard would be he was so fit, he was played football, he did this, he did that, and there were no warning signs. But when you drill down, and often this entails going back and talking to the family and to coaches and to teammates and to girlfriends, there was unexplained syncope in 32%, and it was relatively recent, within a year in 9 and within a month in 11. Also, if you drill down, and again, the family history is paramount, and we don't collectively as cardiologists, we're not like geneticists in the way we do this, but we need to drill down to much greater extent and get a three-dimensional pedigree. Look, they were 30% had a family history of sudden death under the age of 40. So these should have been red flags and should be red flags to us. The diagnosis, what is incomplete disease expression? What is early disease expression of ARVC? This is data published from our group by Johnny Cuarta. He was scanning ECGs onto the database, and he commented, he said, there's anybody that has more than 4 or 5 ECGs, they vary. And this is one example where on the left-hand slide in panel A, in November 2003, essentially normal V1, V2, V3. And 15 months later, T-wave inversion, V1, V2, V3. 2 months later, normal again. And then 4 months later, abnormal again. And this variation is also seen with the epsilon waves, which shown here. And overall, just a summary of this entire data set is that 20% of the patients had dynamic changes, particularly with T-wave inversion coming and going in right precordial leads. And when you looked at which patients these were, they were younger, had better exercise capacity, had less imaging abnormalities. This was early disease. And I think we now recognize that from this and anecdotal presentations that early on, the desmosomal variants can impair conduction sufficient that you have arrhythmias and risk of sudden death before you get myocyte loss. So the arrhythmia is not a scar myocyte replacement arrhythmia. It's a impaired conduction, altered conduction mechanism of arrhythmia. And in terms of picking these people up, we need to be looking at subtle ECG features and not being reassured by the fact that there's an MRI and echo are normal. Age-related penetrance, again, important. So seeing somebody age 20 and you need to continuously review them, the precise time periods are not that well established, but there's definite age-related penetrance to go with, or age-related disease expression to go with the incomplete expression. So in summary, with this concept of normal imaging, abnormal ECG, T-wave inversion, there's different approaches, and I think I would stay above the line. So this physiological adaptation in the elite athlete with T-wave inversion, I think is the diagnosis of the destitute. I think it's until proven otherwise, this should be considered, these features should be considered to be potentially incomplete disease expression. The same, the racial variant, I know the recent literature with T-wave inversion in Afro-Caribbean, African, or individuals of African origin, particularly in football, with biphasic T-wave, with J-point elevation, racial variant that's been published. I still think there's a lot of difficulty and issues in sorting that out. And a safe way to look at this is actually when you see changes like those changes with T-wave inversion or biphasic T-waves, certainly consider incomplete disease expression of one of the HCM or ARVC disease genes. It may be inadequate imaging, particularly the apex and HOCM, and sometimes the right ventricle in ARVC. Also, there's performance-enhancing drugs, which also can confound the situation. More recently, and the arrhythmogenic cardiomyopathies, actually, a lot of them, a characteristic feature is actually low voltage. And that's particularly with FLNC and RBM20 and Desmond. So, but basically high sensitivity to abnormal ECG as potentially incomplete expression. So in summary, I think in terms of the clinical and the genetic epidemiology in relation to identifying those with a time bomb that could go off, the first is that our contemporary understanding of the clinical and the genetic epidemiology, I think, underscores the importance of incomplete and age-related disease expression for the majority of the sarcomeric, desmosomal, nuclear envelope, and ion channel variants, which are associated with these conditions. The second issue related to that is that you have to assume that when you have incomplete expression, that there is potential risk of arrhythmia, and this needs to be better defined in terms of the family and the genetics. So a detailed family history, and ideally with a three-generation pedigree, and focusing on disease events at a young age will help identify individuals who may not fulfill the diagnostic criteria, but who they may nonetheless be a ticking time bomb. And in terms of questions, so we've had several questions which we can look at, but just as a summary, there's about 5 bullet points here. The question is, which two of the following statements are not correct? The first of these is that despite the absence of contemporary population-based epidemiological studies, the prevalence of HCM and DCM can be reasonably inferred from other data sets, and it's approximately 1 in 500 and 1 in 250. The second question, and we're looking for the two that are not correct, the patients with an arrhythmic clinical presentation who have mild to moderate LV dilatation or impaired systolic function may be correctly diagnosed with DCM rather than ACM. So is that the right diagnosis? The third bullet point is the focus of management in patients with arrhythmogenic cardiomyopathy is to prevent life-threatening arrhythmia. The focus of management in DCM is to treat heart failure and prevent heart failure progression and complications, which in the later stages may include arrhythmia, but you don't die with DCM walking to work from the more typical cytoskeletal gene abnormalities. And the fourth bullet point is there should be a greater emphasis on ascertainment of familial disease, and that this would help identify patients who are a ticking time bomb. Correct or incorrect? And the final comment is that mutation analysis and the identification of a disease-causing gene in an athlete will reliably identify individuals at risk of complications. In other words, those who are a ticking time bomb. So two of those are incorrect. Which two? So thank you for your attention. Hopefully the correct answer to this question, which two of the following statements are not correct, will be straightforward, and that means I've done a good job. If we get the wrong ones, that means I need to go back and start again. But thank you for listening, and thank you to the organizers for actually keeping this meeting going, and with this novel approach, which probably increasingly will be something that we'll need to do in the future. And thank you.